Welcome to the Turd Nerds podcast. You are tuning in to the Functional Gastroenterology podcast with hosts Dr. Alana Gurvich, Dr. Ami Kapadia, and Dr. Rebecca Sand. Let us tell you quickly who we are. I am Dr. Rebecca Sand, a naturopathic physician, acupuncturist, and educator based in Portland, Oregon. My practice specializes in the microbiome, hormone conditions, and conditions of the gut-brain axis.
I'm Dr. Ami Kapadia. I'm a medical doctor trained in family medicine and holistic medicine with a special interest in digestive health, the microbiome, and its effects on our overall health.
And I am Dr. Alana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, irritable bowel syndrome, and other functional GI disorders.
Okay, let's take the plunge into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Hi, everybody. Welcome back to yet another episode of the Turd Nerds podcast. So the first thing we want to do is just to give a huge thank you to all of the people who have been tuning in and listening to us and sending us love. Just so you guys know, we have over 16,000 downloads.
That's amazing.
It's kind of amazing.
Yeah, we love you guys.
And we appreciate it. And we're just trying to continue to put out content that is useful for everybody out there, which brings us to this next podcast topic. Till this day, our number one episode that has ever been downloaded is our episode on constipation. I'm looking right now, and as of recording this, we've had over 1,000 downloads of just the constipation episode. It remains our number one top episode, which means there's a lot of people out there who are struggling with pooping. And so we wanted to take a further dive into constipation, which is beloved in this community. And we're going to have Dr. Sand lead us in a big discussion about chunking out the different subtexts of constipation.
That's an interesting word choice there.
Can I share just a quick side note on this topic?
Yeah.
I decided that I was going to try to pay my nieces to listen to like a teaching module that I wanted to teach them for money every month or two. So I tried to teach my...
Wait, you're charging them?
No, I was going to pay them. I told them it was like work. It's like a job where you might not want to go, but they pay you.
Got it.
Would they be interested?
Yeah, totally.
And they said so my younger niece said, as long as I get paid, I'm good. I'm good. But then today I did try to do a 5-minute constipation discussion after I saw her magnesium gummies that I forgot to give her from the night before. She was not interested. I even upped the payment.
Can I do it for you?
Wait.
But then my husband said, why don't you tell me the information? And then she was forced to listen.
Okay, wait. Now, just out of curiosity, how much were you paying her? Because that might have been the problem.
We asked her to name the price. She said $2.50 an hour.
Oh.
And so I was going to do more. I was going to up the actually per minute payment for the brief 5-minute discussion. But she wouldn't go for it. She prefers quarters for payment, and I had the quarters on hand.
Got it.
I wish that would last. It won't, but I wish it would.
So everyone needs to know about constipation.
Yeah. Boy,
Okay.
is that the truth.
Dr. Sand.
Yeah.
Tell us about constipation.
Well, so today we talked about quite a bit. We've talked about prokinetics. We can talk all about drugs and whatnot, though we've covered quite a bit of those already. What I really want to hash through today is subtypes. The different types of constipation, how we know the difference. But let's stop and talk, why do we care? Why do we think we care about the different types of constipation?
So it could help figure out what kind of treatment, where to aim your treatment.
Yeah.
And also just for empathy purposes?
Yeah.
Oh, not all constipation's the same.
Yeah.
I respect and value, and I understand your constipation.
Yes, we're all unique butterflies.
Yes.
Also very important. Good point. But yeah, figuring out the underlying cause, it's sort of a way to kind of inch towards like, why are the bowels not working? It guides treatment. And then, of course, as we all know, trying to get prescriptions through on some of these drugs, the dosing's different depending on what drug we're trying to prescribe. Some are approved for different subtypes, some aren't.
I will also say, when I was putting together a presentation about the like basically subtyping constipation, I, as a GI specialist, don't even think I understood that there were different types of constipation.
Yeah. I know. It just, you don't poop, right?
Right.
Yeah. Well.
And oftentimes you're not asking follow-up questions for your patients. You're just throwing magnesium at them or Miralax at them, depending on what specialty you're under.
And I will say, like, there are great algorithms out there for guiding how you do the formal workup. A lot of these are sort of diagnoses of exclusion on top of diagnoses of exclusion. And, you know, we are not doing, like, manometry tests. We're not doing balloon expulsion tests in office, you know, so we may not get to the bottom of this, but we certainly can work with people who do it, and it may be useful in some cases. So let me just list off a bunch of types of constipation that have ICD-10s associated, and then we'll figure out how we put them together in the umbrella categories. So we've got IBS with constipation. Mm-hmm. We've got mixed IBS, that includes constipation, chronic idiopathic constipation, functional constipation. This is like a third of the list, so it keeps going. Atonic constipation, outlet dysfunction constipation, primary constipation. Have you heard of all these before?
Well, I've definitely heard of them. I just wouldn't know.
Aren't
some are synonyms.
Okay, I was going to say, if certain ones fall under primary.
Yep.
Okay. And if you see me about to laugh, it's because I have another side story we could get to later. No. I have a question about dogs and smelling poop. So we'll discuss it after.
We the right people to answer this question?
I will just say that.
I don't understand this.
At one point, I realized that dogs, nothing smells bad to them.
Okay, because we were at the park this morning.
Yeah. Can we just stop? Wait. No, like nothing smells. It's all just
Is that true?
Yes, dogs do not have the disgust.
Okay.
Nothing smells bad. It's just another.
Blew my mind with that.
I know, isn't it crazy?
I feel like my kid's the same way though.
Mm-hmm. At this age.
Yeah.
You will pass that point quite quickly.
Are you sure?
Yes.
Well, there have been some pretty. I mean, some of those diapers, man, are just.
Okay.
And she doesn't mind.
I am like gagging.
Okay.
And, yeah, poor sweetie.
Yeah, I know. And when you go from nursing to food, it is a shock.
Just when you started the talk, I felt that I might start laughing, and I wanted to tell you why.
Okay, so what happened at the park?
So we're at the park this morning, and
we're gonna pause the list for this quick story.
There's many dogs there, and we're just walking along, and this dog runs up and jumps into my other niece's butt, basically.
Yeah,
like,
totally.
Why do they go right for the butt?
Because there's nothing as a bad smell. It's just all odor.
And they know that's where the butt. Like,
yeah. They definitely know.
Like this guy needed to have his dog on the leash. I was worried about something.
I've had many a dog.
Yeah, and then
or what if you're wearing a nice coat?
The backside or the front side.
Yeah.
I mean, if they can smell epilepsy or Parkinson's disease, they can definitely smell what hole.
All right. Well, anyway, that was just another. So on the way home, I asked if we could walk away from the group of unleashed dogs.
Yeah.
Okay.
Yeah.
That's it.
You're clearly not a dog owner yet, Dr. Kapadia.
Yeah, and if my dog will not eat poop.
Oh, sure it won't.
I've asked many people, you can train the dog to not eat poop, I've heard.
I mean, kids eat boogers.
It's disgusting.
Adults eat boogers.
Can't.
Yeah, that's true.
That's really disgusting. I still have a memory from childhood of this girl in the front seat. Yeah. Her dad was driving us, and
I remember I tried it once because I had this is
you only tried boogers once?
Well, I had my things, but that wasn't my thing. But I remember everyone's really into this right now, and I remember I snuck away and tried it, and I was like, I don't know what the big deal is.
I can't handle this. Can we go back to the list?
We'll go back to poop for you.
Okay, yeah, let's go back. So we ended at primary constipation, which is a synonym.
Yep. Slow transit constipation. The category of defecatory disorders. Slow transit constipation, normal transit constipation. Oh, I said slow transit twice. Spastic constipation, unspecified constipation, and drug-induced constipation. We also have atonic, which we'll get to. So that's a lot. Yeah, it sounds kind of like a headache, but luckily they go into 4 main categories.
Okay, that makes sense.
Yep, we've got irritable bowel with constipation or mixed if there's crossover. We've got chronic idiopathic, which is also known as primary or functional. And then we've got the drug-induced and atonic.
Okay, that's more manageable.
Yep, and we've heard of those. We can even tell by the name how they differentiate.
IBS.
Yep.
Idiopathic.
Yep.
Atonic.
Yep.
And drug-induced.
Yep.
So outlet constipation.
Yep.
Would be under atonic.
Nope. Chronic idiopathic.
Oh. Mm-hmm. And pelvic floor dysfunction causing constipation, also idiopathic.
Yeah.
Interesting.
It's like outlet. Yeah. Pelvic floor is the outlet.
I don't think I would have placed that, to be honest.
So let's go through them all, and we'll get some more information here. Diagnosing. We don't have to harp. Well, do you want to cover the Rome 4 again?
I don't think we've heard this. Can you just read it out?
Okay, sure.
Yeah, let's just read it out.
The Rome 4 criteria for IBS is bowel movements associated with recurrent abdominal pain greater than or equal to 1 day a week in the last 3 months on average. Plus, you must have 2 or more of the following. Abdominal pain that is related to defecation, and this pain notably can be increasing, unchanged, or improving. Or associated change in stool frequency or associated change in stool form or appearance. So 2 of those last 3 need to be with
I don't know if we've ever said that on this podcast. I don't know if we've ever discussed the Rome 4 criteria.
But it's pretty Googleable.
Yeah.
So that's IBS. And the big difference between the Rome 4 criteria for that and for CIC or functional constipation or primary constipation is the pain.
Right.
You have pain. And that's why the treatments vary so much. Things like Miralax that some associations will recommend for chronic idiopathic but not irritable bowel is because it doesn't take care of the pain.
Yeah.
It can totally get you pooping, but it will not cover it, and it doesn't change treatment-seeking behaviors. Yep. People are still miserable. So that's why it's important to differentiate. But
so wait, just one more time.
Yep.
For IBS-C,
Yep.
you need to have that component of pain.
Yep.
Period, full stop. That is the one guarantee of IBS.
Yep.
Great.
Yep, you have to have recurrent abdominal pain greater than or equal to 1 day a week within the last 3 months on average.
And then 2 of the other category.
Yep.
2 of the other.
And what are they saying? Is constipation designation for how many bowel movements a week?
No.
They're not designating any constipation bowel movements a week.
Not according to the Rome 4.
Am I like getting ahead of myself? Are we going to designate how many bowel movements it should be a week?
You could make a new criteria.
Yeah, it's called the Alana Garbage criteria.
Let's be honest, it's not. I'm never going to get a concession with my criteria.
You never know.
But because I've heard anything from anywhere
once a week,
twice a week to once a day,
6 times a day.
Yeah.
Yeah. There's a big range of normal. So chronic idiopathic is basically constipation you can't attribute to something else, and you don't have abdominal pain associated with your bowel movements. The technical Rome criteria is at least 2 of the following for greater than 3 months, with symptom onset greater than or equal to 6 months prior.
Oh, wow.
So, I don't know.
They have to be constipated for a long time.
Who's really, paying attention to all this, and who's honestly diagnosing it with these formal guidelines, but this is what it is. So these are the symptoms: straining during at least 25% of bowel movements, hard stools at least 25% of the time, feeling of incomplete evacuation at least 25% of the time, sensation of blockage or obstruction in the anus or rectum area at least 25% of the time, manual efforts to engage or enable the passage of stool, like digital evacuation, at least 25% of the time. Less than 3 bowel movements per week.
Okay.
Rare occurrence of loose stools without the use of laxatives. And then obviously you have to fail to meet the criteria for IBS.
Okay, so I just had a patient who I saw last week who it was a very interesting conversation. She's an inflammatory bowel disease patient, but she is very stable on her IBD diagnosis. But now she has terrible constipation. And we were talking about it, and I was like, it's sure, like, did you prolapse from your babies? Did you prolapse from your babies? Yeah. And she's like, I don't know. I pushed a long time. Maybe nobody ever told me. And I was like, have you ever splinted? And she was like, what? What's splinting? Yeah. And so I explained to her, when you insert fingers into the vaginal cavity and push towards the rectum. So you make like this basically external muscle so you can engage the pelvic floor.
Or you can use a diva cup or something.
Or you can use like some kind of firm object, like a tongue depressor or a spoon.
Yeah. They make splints for it.
It's kind of, and she like
for rectal prolapse.
For rectal prolapse.
Or bladder.
Right, or bladder, or but she was like a little bit, her mind was blown that you can use something external. Like women don't necessarily figure this stuff out on their own, but you can use something external to mimic the muscular tone of the posterior aspect of the pelvic floor, and it can make a huge difference.
So what do you tell them? Do you have them get this device? Or
I just have them start by washing their hands. Wash their hanurs first, because you obviously don't want to introduce other bacteria into the vagina, and then use your fingers to see if that offers any solution.
Did that help her? Or?
We're having a follow-up in a couple of weeks.
Okay.
I send a pelvic floor PT.
I gave her a pelvic floor PT referral.
Yeah.
So you can use the splinting until they regain the muscular control, and maybe. And if they've had vaginal births, we should ask about. Well, they might not know that, like your patient,
or chronic constipation.
they might have a partial prolapse, but usually you would think it would be like someone post-pregnancy or no?
I mean, definitely pushing out a baby is more likely.
But do you think you could just get it
from constipation?
Yeah.
From wrestling out your stool for years and years and
years.
If
they don't know how to breathe properly, especially probably during, which have we talked about that?
No, but this is a good episode.
That was a great tip from SSL's lectures. You guys know better than me, but
I recommend it to my patients.
Don't keep us waiting. Tell us, what is it?
I feel like he says to just it's similar to probably pregnancy breathing, right? I don't have kids, so you guys
a little different, but
he says to when you're so you don't cause excessive intra-abdominal pressure, you breathe out as you try to have a bowel movement.
You breathe out. Or you breathe in.
I just tell people to breathe because people hold their breath while they're having bowel movements. So I just say, like, I've had whole patients that was the issue. Like, we did some stuff and got things regulated, but they were just holding their breath when they were pooping.
Well, if you breathe in, you're increasing intra-abdominal pressure. So I think he has a whole thing on it that he gives in his lectures.
Yeah.
I mean, you don't have it memorized, so you guys probably listen.
I just have people breathe.
Okay,
I don't know.
I'm pretty sure he like emphasized you want to
breathe out.
Sure,
breathe out as you're having a bowel movement.
Yeah, makes sense.
All of these things, they're just not thought of.
Right, like we never learned that to teach patients that, you know.
Yeah.
No.
Yeah.
That, and he said it was like a big key to prevent all kinds of
secondary issues,
types of issues. So
yeah. Well, should we dive into some of this stuff? Okay.
Let's go further. I've learned already a lot. We should just end it right now. I've learned so much.
There's IBS. Okay, so we covered IBS. You have abdominal pain. We have all heard of that. Let's get into the subtypes of chronic idiopathic or functional or primary constipation. So again, these include slow transit, pelvic floor dysfunction, or the whole group of defecatory disorders, as well as normal transit constipation. And I should say a lot of, these are debated. There's overlap on the categories. Some people, we can talk about atonic constipation. Some people don't consider that a type of constipation. I mean, it's just, people love to debate categories, but
I love that.
Generally, this is where things are pooled. And there's overlap. Like, you can obviously switch into IBS and out of IBS, depending on what's going on and treatment and whatever. Okay, so slow transit constipation. This is 15 to 30% of constipated patients. It's considered to be a disorder of the autonomic and enteric nervous systems and or a dysfunction of the neuroendocrine system. So think of all the things that could be at play there. Generally, it's a delay in food moving through the intestines, and we see dry stools that are difficult to pass and leave that feeling of fullness after eating, and we see bloating with this one. So, the tube just isn't moving. People here, we think maybe what's happening is they have a lower amount of those interstitial cells of Cajal. Which you may remember are the colonic pacemaker cells, we call them.
I always thought it was Cajal. Cells of Cajal.
I mean, that sounds cool.
Is that another language?
I don't know. Cajal, but
is it Cajal? Okay.
I don't know.
I feel like I've heard it both
Tell us,
ways.
turd nerds. Yeah.
Yeah, and also let me know if I was wrong about how I've been advising my patients on breathing.
I think the most important is just hyperventilate when you're pooping.
Hyperventilate?
Yeah.
Okay, so we should just,
I think that's
just start recommending that.
That's what you do during childbirth.
Okay, that and the pronunciation of these cells. Let us know what you think.
Yeah.
Anyway, we need those cells. They aid in the transfer of signals between the muscles and the nerves, which is obviously hugely important if we're moving things through. So in folks with this slow transit picture, we generally see impaired colonic contractile responses to both laxatives and neurotransmitters. So things working on neurotransmitters, even things like motegrity or prucalopride.
Wait. So what we see with these people is they have a lower sensitivity to respond to these neurotransmitters
potentially.
Within the goal. Okay.
Yeah, I mean,
it
depends on where the breakdown is, but some of them it may be the neurotransmitters aren't firing right throughout the digestive tract, whether it was damage of the receptors or serotonin is insufficient or,
right.
any of that can cause it. So obviously if the drug is helping with the lesion or whatever it is, great. Okay. But we may not know. They may exhibit weaker, absent even electrical activity in parts of the GI tract or throughout, depending. And then this can involve all sorts of things related to neuroendocrine signaling. So pancreatic polypeptide hormone, serotonin, like we just said, substance P, cholecystokinin, all the things that are just governing, okay, time to move in the digestive tract.
And we see this mainly in women. Do you know?
I think constipation in general,
yeah.
But I don't know off the top of my head for this subtype.
Okay. I just assume that we just see this mainly in women.
I do.
Yeah, I do too. But
well,
but I think
also see your patients are mostly
we
women.
see mainly women.
Yep. Yeah. So, it's a bummer. This one's a bummer, and it's helpful to get that wireless motility capsule for this, because it not only can just confirm the diagnosis and you're more able to get the drugs, but we can see where in the digestive tract.
So like being stalled. Doing a pill endoscopy is what you're saying.
Wireless motility capsule. So it's not the endoscopy. It's not the camera.
Yeah.
It's pressure, temperature, and pH.
Oh, interesting.
And that is different. It's still a giant robot pill, but it doesn't have the camera attached to it. Hard to get covered.
And it measures the actual transit in different areas of
Yeah, so you can see it's like small bowel or large bowel or like ascending colon only, or if there's something that gets stuck for some reason that we haven't been able to scope, it can elucidate that.
Yeah, too. I feel like I've seen that rarely that a patient has had that. So it's just probably the insurance coverage issue.
It's always,
Oh, the capsule.
That they've actually had that done as part of their workup.
I've seen a couple.
Yeah.
Really, I've had it done.
You have had it done?
Uh-huh.
Was it...
Did you have to ask to have it done?
Or did they I had a series of crying in gastroenterologist's office asking for it. They required it before they would prescribe me Motegrity, but that was like the year it was approved and doctors didn't know about it.
And they track it through like Bluetooth?
I don't know how they track it. They sent me home.
And then they get a reading, or you have to bring the pill back?
No, I never saw the pill.
I mean, that would be great if primary care practitioners could just order that.
Yeah, but the question is, do we know how to analyze it?
Right, I would think it comes with a report.
The report wasn't, it's really just like, abnormalities in pH, temperature, and then the pressure as you go through, and then the transit time of the device. Right. And it tracks, small and large bowel as best it can and where it is, and then when it left, and obviously hit, hopefully, a toilet bowl. So... Hopefully. I don't know. I'm
Everything's becoming... We're all going to have our own trackers at some point.
Yeah. I mean, we are going that way, and it's kind of cool.
I think it's quite expensive because it's like a disposable giant pill, and it was a thing to swallow, I'll tell you that.
Oh, really?
Oh, yeah.
Like a horse pill.
I'm one of those people that can swallow a handful of pills. Like, I'm fine with that, but it was tough.
Wow,
so
okay.
I prep my patients if they are going in for that. Even the endoscopy one is hefty. I'd say,
Oh, wow. So it's like a quarter width.
Probably.
That looks about like the width of a quarter.
So a choking hazard?
I'm impressed. They give you some kind of like radioactive granola bar or something beforehand. I'm not really sure how it works, but it's some fancy granola bar.
Do you think it's still in you?
I'm sure they...
Don't you see me glowing?
That's what it is. Yeah.
Exactly. At all times. So anyway, it can be helpful.
Okay.
For people. So, the second subtype here is pelvic floor dysfunction or all of our defecatory disorders. So, in this subcategory are anismus, dyssynergic defecation, anal rectal dyssynergia, and the list goes on. The whole
dyssynergia is defined as a lack of communication between the nerves and the organ. Is that how we define dyssynergia?
Sure.
Okay.
The nerves are dysfunctional.
And you're supposed to be able to tell that from a manual rectal exam.
I think I'll go through the flow chart of the workup because I have it pulled up. Unfortunately, I can't show it to our listeners, but it is Googleable. This one is characterized by a couple things. One is those paradoxical contractions or inadequate relaxation of the pelvic floor muscles. So, or it can be inadequate propulsive forces when trying to have a bowel movement. So this, when I talk about it, and you've probably heard this analogy too, of like the car in the garage, and either the garage door's open and the car's off, so it won't go anywhere, or the garage door is closed, but the car's on and ready to move.
Thanks to the power of the internet, dyssynergia is defined as any disturbance of the muscular coordination resulting in uncoordinated and abrupt movements. Yeah. That makes perfect sense.
Yeah. So like a car trying to leave the garage, but the door's shut, or vice versa. So the signaling isn't quite there. This one's an important one to be able to recognize as best we can and test for, because laxatives aren't necessarily going to work. They're just going to get raging diarrhea when the doors decide to open in tandem.
Which might not be when they're by a bathroom.
Exactly.
Yeah.
So the pelvic floor therapy would be more the treatment.
Biofeedback is another one that's been pretty well studied,
and I feel like that's becoming more mainstream as a recommendation.
Yeah.
Can I tell a quick pelvic floor story?
It
is something that I share with my patients. Not really, but a little bit. So when I was pregnant with my first child, I was reading this book out of it. Like they have an American translation, but it's originally written in France, in French, and it's called "French Babies Don't Throw Food." I think in the U.S. it was called "Raising Baby" or "Raising Baby," something like that, right? And in that book, she talked about, so I was pregnant and my child's 11, so this was 12 years ago. She talks about how in France, 6 weeks after you deliver your baby, every single person sees a pelvic floor physical therapist.
As it should be.
Stock. And I was like, pelvic floor physical therapy? 12 years ago. At this point today, I can think of 10 incredible pelvic floor physical therapists that I refer to regularly in Portland. Like the amount of advancement in the to understand that the pelvic floor needs therapy.
I mean, it doesn't take that. I mean, obviously, is all I have to say to that.
Except it took us a long damn time.
Yeah.
So maybe it should be standard post-pregnancy.
I mean,
of course it should be.
A lot of stuff
happened.
An
evaluation.
Yeah.
A lot of stuff
Probably
happened.
even during pregnancy. I mean, carrying that much weight and everyone gets constipated. You know, it's a lot.
Not everybody.
Well, that's true.
But a lot of people.
Most people.
Yeah.
It's a lot to ask of a pelvic floor to house a human being and then push it out.
Yeah, it's true.
Anyway.
Okay.
So this one basically, to summarize, is characterized as the muscles around the anus, the rectum, the last of our digestive tract are too weak and or too tight to allow for things to move smoothly. We see this a lot in our aging populations. As we age, we know that our colon changes in its plasticity, its compliance, and its structure, so like diverticulosis. And we see altered control of the pelvic floor. That obviously affects urination too. Patients with pelvic floor dysfunction or this subtype of chronic idiopathic constipation often describe a feeling of obstruction in the rectum. And then they may have pain during bowel movements and that sensation of incomplete evacuation. And this one is most common in elderly females, particularly those with a history of anorectal or pelvic surgery, pelvic floor trauma, and of course, childbirth.
I mean, also the amount of women who are getting anorectal surgeries is definitely increasing.
Really?
Yeah, for sure. Especially as they age. Yep.
To
correct prolapses that they had during their childbearing ages, or to deal with.
Or if they had a hysterectomy, and that statistic we talked about with the amount of prolapse after hysterectomy.
Yeah.
Yeah.
I mean, yeah. Yep. So that brings us to normal transit constipation, which is the last subtype of chronic idiopathic constipation. This one is you've ruled out slow transit, you've ruled out pelvic floor as a cause, and you land here. This may be the most common type of CIC, but we have a lack of data because no one's really formally diagnosing this for the most part. It may have some relationship to gastrocolic reflux. You know, which I thought, was interesting. Yeah. Something there is not working right. Neuronal or muscular tissue that controls our bowel movements. Something just isn't signaling properly. And these patients often describe difficulty passing stool, a sense of urgency and straining, but maybe not just at the rectum. So, and there was one study that I was reading through that showed that some patients in this subgroup may have increased rectal compliance, reduced rectal sensation, or both. So a lot of theories on like what could be going on here.
Increased rectal compliance means that they're not as responsive.
Yeah, well, it can just, the bowels can just distend instead of move things through. Yeah. So more elasticy and stool can accumulate, and or they may not be able to sense the sensation.
Yeah.
Sort of like the opposite of visceral hypersensitivity, at least in that area. So, so what I've got here that we can kind of read through is the formal workup for this. And this was from the journal Neurogastroenterology and Motility. But basically...
What was the paper titled?
Diagnosis and Treatment of Chronic Constipation, a European Perspective.
Okay. I'm gonna not look at your chart and just listen to see if I can track it.
Okay. So... basically, if a patient comes to you with refractory constipation, no improvement with high-fiber diet, laxatives, and prucalopride they have on their list.
Because it's Europe.
Because it's Europe.
Yep.
Is that first line over there?
Yeah.
It's been there for so long.
It is on this 2023 recommendation. Then you do physiological testing, which includes anorectal manometry, rectal balloon expulsion, and a colonic transit study.
Okay, makes sense.
If the anorectal manometry and balloon expulsion are normal, then we can ask, is it colonic slow transit or functional constipation with normal transit based off of a colonic transit study, which you can also just be like, try some beets. Let's see.
Oh, yeah. Like, so you're saying for your own at-home test.
Which I ask,
yeah.
Or I tell people, like, go eat some beets.
Or corn.
Let's see if it's 12 hours or 5 days, or somewhere, because 3 days can be normal.
Yeah.
Which feels uncomfortable. If both tests are abnormal, meaning the anorectal manometry and balloon expulsion, then we're looking at potentially doing a barium or MR defecography. How do you say that?
MR you're right.
Yeah.
You nailed it. You have to say it with authority. Just say it with authority.
I know. Because then we're kind of looking at functional defecation disorders, which can overlap with colon motility. You can have an outlet disorder as well as a slow colon or slow small intestine.
Which is a double bummer, just to say.
Yeah. So basically, like, you can do imaging, you can do all these studies. We have them available. There are guidelines for them if you want to look them up. And it's hard to do.
I will say
They're not fun to do either.
That was like the most logical presentation of workup that I've ever heard.
Well,
like,
we haven't even covered a couple of them.
Well, no, for the CIC.
Oh, yeah.
Yeah, like the workup basically is try laxatives or try fiber first, try laxative second, try a prokinetic that works to move things.
Which is what I do.
Right, exactly. It makes sense. Okay, it doesn't work. Now let's pay the $1,000 or the $1 million to do the manometry, to do the balloon expulsion.
Yeah.
It's just logical. Like, it makes perfect sense.
Yeah, because we're kind of like singling out where in the digestive tract is the problem, so we can go in and fix the issue. But let's start some things that may be great treatments to begin with.
Yeah, knowing that they have efficacy. Yeah. There's an obvious efficacy with fiber. There's an obvious efficacy with laxatives, except we're worried about the laxative dependence.
Yeah, and I think, if we can get the bowels moving, like we've talked about before, does abdominal pain go down? Does bloating go down? All the symptoms that go along with constipation, do we get traction there? Or maybe we are able to get people pooping, but that abdominal pain persists.
Right, so you can figure out if it's like IBS or just constipation.
Yeah, because if that's the case, if we can do fiber, but they still have abdominal pain, add some peppermint or, like easy. Right. We don't have to go through all this. So yeah, I think it makes perfect sense.
Wow, that was super interesting. That I think I might have made a ton of connections that I didn't really understand before.
It's cool to know the different subtypes because you get a better idea of where the breakdown is for people, and that allows for more targeted treatment, especially as more and more drugs come on the market. We can kind of figure out where the issue is and then being able to poop and help them with that issue.
Okay, so let's just do a quick recap right now, and then we'll come back, in a couple of weeks and talk about drugs and other interventions.
Yeah, and then we still have 2 more types of constipation to cover.
God, we can really spend days.
It's much more complicated than you would think.
Yeah.
It's much more complicated than, I'm constipated.
Right.
Yeah.
I mean, it is, and that is kind of what is amazing about modern medicine, is there are all these microcosms.
Yeah.
What's amazing about, like, Ayurvedic medicine and Chinese medicine is it's all the same thing. Yeah. But it is interesting for interventions.
Right. Yeah.
Okay, let me try to do the recap.
Okay.
So what we talked about today is really IBS constipation and then chronic idiopathic constipation.
Yep.
IBS constipation is either IBS-C or IBS-M.
Yep.
Chronic idiopathic constipation is going to be slow transit or constipation, pelvic floor constipation, or normal transit constipation. Under pelvic floor, we also have defecatory disorders. Mm-hmm. When we're looking to rule it up, IBS is always going to have some kind of pain conglomerate. Mm-hmm. CIC does not need to have that pain. CIC needs to be less than 3 bowel movements per week, and then some kind of straining, some kind of changes to the constitution of the stool. And then for workup, we're thinking first fiber, then laxatives, then precalcipride according to Europe, not according to the US. And then we start doing the workup for anomanometry and balloon expulsion, which, by the way, are very uncomfortable tests.
I know,
they're a bummer. Yeah. Did I miss anything? What did I miss on
me? I need to listen to this episode again.
I think I know.
And take some notes.
I think I know who's going to be editing it.
I will be editing this episode.
Okay, Dr. Sand, this was awesome. Thank you so much.
Thanks for tuning in.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.